call myself a cynical optimist because I've seen the realities of the system that we exist in, but I couldn't do the work that I do if I wasn't optimistic, if I wasn't a believer that there is a better world as possible and that we can create it, and it's up to us to create it. And I want to be a player in trying to make that system better. And so I do like to work in innovation, and I like to work in policy, and I like to build systems because I think that's how we make a better world. But I also understand the realities of the confines of those systems, and it makes me very cynical. And so that's where that stems from. And I've worked in the policy space doing advocacy work enough too to see the marginal change that we can make in a policy level, but also been really hopeful by seeing some of the changes that we do make. And so getting to do that work makes me optimistic, and yet I'm cynical about what we can get done.
Today on Bluestock Talk, we have Dr. Taylor Nichols, who is a board-certified physician in both emergency medicine and addiction medicine, and a nationally recognized voice in health policy and patient advocacy. He completed medical school at UC Davis, followed by emergency medicine residency at UC San Francisco General Hospital. He serves in multiple clinical and leadership roles in addiction medicine and health system innovation, and is widely recognized for his work advancing health equity, substance use disorder treatment, and healthcare policy reform. Dr. Nichols, welcome to Bluestock.
Thank you so much for having me. I appreciate it, Allison.
Absolutely. So I have been a longtime follower of yours. I think we got introduced via LinkedIn, and I have just really enjoyed a lot of the things that you repost, things that you comment on. And I think you and I align very closely on a lot of our feelings about what's going on in the world. But with that all said, I have been extremely fascinated in your history with addiction medicine work, and especially because I know you grew up in the Bay Area, so you sort of have this nice mix of startup culture and your medical side, and you're bringing all those things together. And that focus in addiction medicine work has been really interesting to me. So maybe give us a little background on how you got into that, and what's your current work on that?
Sure. So I am emergency medicine trained. I did my residency at UCSF in emergency medicine, and am board certified in emergency medicine. Have been, on the front lines in the emergency department since I finished residency in 2017. You see everything, including people who are struggling with substance use. And it really felt like an opportunity to do a little bit of work upstream. You see sort of the consequences of the system, where the system has failed, and the gaps in care. And that felt like a very addressable gap to me. And I have a personal history with, my father has alcohol use disorder and opioid use disorder. And so that really sort of spoke to me. And also seeing the way we treat people who use drugs in the emergency department, and the way we could do that better, and the way we sort of maybe perpetuate stigma, perpetuate harm within the emergency department and in the healthcare system. And I didn't start being interested in that field necessarily, but I more and more recognized that we were causing harm. And I felt like the only reasonable response to recognizing that harm was to seek to reduce that harm. And so I became very much sort of a harm reductionist from the emergency department. That may be counterintuitive to some people, but I recognized that we could do it better, and that people responded better when you approach them with love and compassion and seeking to help. And I felt like that was an area where I could focus my attention, and part of what I'm good at, what made me good at in the emergency department. And so I really transitioned a lot of my life these days now to addiction medicine. I still do both emergency medicine and addiction medicine clinically, but I work much less in the emergency department, and most of my time is in addiction medicine, and really trying to find ways that I can sort of reshape the system as best as I can. I'm the medical director of an outpatient, like a full scope addiction treatment clinic. We take walk-ins, anybody can come in I'm in Sacramento, California. Our clinic's called Transitions Clinic of Sacramento. And then I've built a medical group sort of on top of that to provide care in clinics, in hospital setting for consult services, to improve care in the hospital for people who are struggling with substance use, and then supervising, rehabs or residential addiction treatment facilities. And that leverages a little bit of that startup culture that I was raised in, and in the Bay Area, and the work that I get to do clinically with patients. And so kind of incorporating a few different facets of my life. And I think being emergency medicine trained has served me incredibly well in the field. And it's given me a lot of context for where I think there are gaps and where I think we can do better. But a big part of that in my role, and trying to be sort of pushing this change in narrative forward, is that we can change the stigma against drugs and the people who use them. And part of that is through reframing the way we think about and talk about people who use drugs, or talk about drugs in general in society. We're very stuck on this like dare,
Yeah.
moralizing language and view. And I really hope that, at some point we can reframe that.
That's actually one of my next questions for you, is because I feel I talk a lot about how we can or how we can reframe how we think and how we talk about med tech, how we think about patients, and even just the words that we use
Mhm.
around those
Mhm.
topics. And I think one of the things that again, I go back to some of the things that you've posted about and some of the things you've been vocal about, is even just the words that we use and how uh, those words really matter. Can you give us a few that you wish people would change the way they talk about it?
So a big thing that I always emphasize is like person first language. I don't call patients their disease. Right? I don't say, uh, that somebody's a diabetic. They're a person with diabetes, or they have diabetes and whatever other conditions they have. So people who struggle with their substance use, or they meet the definition of having a substance use disorder, are a person with a substance use disorder. They're not addicts. They're not junkies. They're not, you get a very different image in your head when you talk about, oh, they're a junkie. Oh, they must be, you know, on the street. They must be, shooting up, and people get this, very specific image in their mind of what that looks like. My dad was none of those things. My dad was a prosecutor in San Mateo County, and very, active and successful in his career as a person with alcohol use disorder. Um, he has been, sober most of my life, but still, it was something that I grew up with, where those dots didn't connect, right? The language that we use didn't speak to my experience. And so either the language is wrong, or my experience is wrong. And a lot of people try to draw that distinguish. Oh, I'm not one of them, or my dad isn't one of them. I saw those people come into the emergency department. I saw people who were struggling. I saw, in my clinic, I like to talk about how my emergency medicine background gave me the perspective, because anybody who walked through the door, and I was in San Francisco. So one minute I'd be seeing a homeless guy, and the next minute I'd be, seeing like a tech executive, right? Same thing is true in my clinic. Like, we take literally, the EMS will bring in people to us like off the street. Anybody who wants treatment can walk in the door. And we have some people who are now very like, have lawyers for the state, and business executives. Same idea, right? Anybody who walks through the door. And I appreciate that. And I also think it shows sort of a breadth of the human experience, and that we need to reframe our own thinking, right? From this like very specific image that we have in our mind. So things like addicts or junkies, or reframing it as a person with a substance use disorder, or talking about abusing drugs. I like to say drugs, you like, how can you abuse a non-sentient, inactive, inert substance, it can abuse you. You are abusing yourself by overusing whatever, your drug of choice is. You can harm yourself that way, but you can't abuse it. Like, what are you doing? Like punching piles of cocaine? Like, no, they're
Sprained my
they are
wrist. Yeah.
they are yeah, right. They are chemical structures. They are compounds that are morally neutral. We imbue a morality to them, and when we use language like abuse, we're painting again a very specific picture in our brain of like what somebody is doing. They're taking an action towards something. And instead, the action is happening to somebody, or maybe they're doing it to themselves knowingly, right? And so I think the language that we use and the culture around that, right? Culture's built upon language. I think the language around that we use plays a huge role in if we want to reshape culture and we want to reshape our thinking. And so, I think the same to your point. I think the same is true that um, medications and devices can suffer from the same kind of stigma, the same kind of like cultural harm that it also we see with substance use disorders, and that we are projecting a certain cultural image onto pharmaceuticals, right? Um, but again, like I say about drugs and pharmaceuticals, to be clear, are drugs, like they're morally neutral. We are only the only thing that gives them any sort of moral valence. And so if we talk about things with a certain context, with a certain tone, with a certain language about pharmaceuticals, about devices, about technology, then we are assigning a morality to a thing that maybe doesn't deserve it. Now, if you want to talk about the system that's designed around those things, that is different. And that's made up of humans who may have a certain morality that we can agree or disagree with. But the entities themselves, the technology itself, like those things don't have any moral value other than what we assign to them and the way we use them.
I love that.
And so
Yeah.
I think when we talk about medtech, when we talk about all of like innovation, right? We're giving it language, and we have to think about the cultural context of the way we are using that language and how we might be assigning a positive or negative value or none, like neutral value to those things. And so I always think it's interesting to watch conversations about innovation or about devices or pharmaceutical companies or pharmaceutical products, because I think we definitely cause harm similarly through what we can view equally as sort of potentially stigmatizing or harmful language.
Yeah. I love I think you said morally neutral, right? Like these aren't um an opioid can actually be really good for you, right? Like it can help with your pain reduction. It is something that is prescribed, and if misused, it could be also something that's very dangerous.
Oh, and so I would say a few things. One, when we talk about endorphins, we talk about like exercise and endorphins or runner's high. Those are opioids. To be clear, like endorphins in your body are opioids. They're structurally similar to morphine, right? Enkephalins are like they're opioids. They bind to opioid receptors. So it's part of your reward process naturally in your brain. That is how it works, right? So like, yeah, and again, part of this is interesting to me. I was a neuroscience major in college. And like the reason opioids work the way they do is because we have opioid receptors in our body. The reason nicotine affects us the way it does is because we have nicotine receptors in our body, et cetera, et cetera, et cetera, right? Like drugs work because of the way they impact the systems that already exist within our bodies. Um, and so opioids are great. Like opioids are fundamental to our existence. So we can't parse out like, oh, opioids are bad, or when people talk about, oh, fentanyl as being bad or whatever, like drugs are only as relevant and valent as we impart to them. I use fentanyl every single shift in the emergency department. For like, it's important for patient care. Like, if somebody comes in with a broken bone, they break their leg, there is nothing that works faster in the emergency department setting. Like, that is the best thing we can do. And so in that context, that is of high moral value.
Yes.
And when it's killing people from overdose, that is, obviously a negative, right? So it's all context dependent. And we have to consider the context it's being used in, the route it's being used, whether or not the person knows that that's what they're using, like all of these things. And so you can't say opioids are bad. Opioids are literally part of how our brain works.
In your physiology. It's like, yeah.
It's the same idea, right? It's all just understanding. The more we understand the impact of the language we use, and the more we understand sort of the like contextualize the information that we are assigning to different things, the better we're able to assess what potential harms that we're causing, right? Like, the more we understand the science of opioids and how they work, the more you can step back and recognize that, like, any moralizing language about it doesn't work. And the more we understand the context of innovation and what it can and can't do and how it may or may not help or save lives or whatever it is, things that are great can be used for bad, and things that are bad that you might think are bad,
They still have
can
value.
end up having very positive value to us. There are things that are poisons that we use for very important things.
Chemotherapy.
I mean,
I always think of if my aunt hadn't had chemotherapy, she would have died. Like, and that's toxic, right? It's like highly toxic. Yeah.
That's exactly the point. Like, so yeah, so you can't really parse out what that itself means, right? It can be great, it can be bad, it can be harmful. It's a net negative on your physiology overall. Like, you're intentionally killing cells. Generally sounds like a bad thing, but like killing cancer cells, net good.
Yeah.
So,
well, net bad for the cancer cells, but net good for the person who's trying to live, right? I think it's like, whenever I look at those like nature programs, and it's like, if we started with the lion cub and watched it grow up and it was hungry, we are so grateful that it kills the gazelle and eats the animal. But if it was a whole program on gazelle populations and you watch, them trying to make their life and on the plains, you're angry at the lion, right? You're like, oh, don't kill the animals. So it's like kind of reframing and giving that perspective. I want to go back to one thing you said about sort of the stigma of opioid use disorder or substance use disorder, and even sometimes the stigma or the bias that we have, not just with drug use or addiction, but even diseases, right? I feel like there's a lot of folks that will look at a person who's struggling with certain allergies or certain even somebody who's has diabetes. Like, what are the ways that we get people to hear what you have to say, right? How do we get lay people to understand that this is a bigger conversation? You have to weigh benefit risk and also use critical thinking in order to not just feel like, oh, that's opioid use disorder, that will never impact me, like, or that's never gonna, that disease is never gonna influence my lifestyle.
Yeah. It's funny to me. We're seeing this happen right now, right? These conversations are happening at a high level right now in the government, where there is this idea that if you are healthy, if you eat healthy, that if you like focus on eating right and exercise, like, then you'll be fine. And we know that that's simply not true. And that entire argument is completely flawed. It really is just attributing. I mean, it's doing two things. It's stigmatizing disease in general, and it is erasing the fact that people don't choose to have diseases. And a lot of these are not things that you just like got from eating too many donuts, like cancer, for example, right? Like at its core, it's this kind of purity argument. It's like only if you eat healthy and exercise and don't have diseases of any sort, weren't born with any conditions, and aren't disabled. That like what
What
world
percentage
is
is
that
yeah.
okay? We're yeah,
Like who's
like
that person?
we're
Do they
just
exist?
exactly. And so right. And so okay, good example. I appear to be the like epitome of exactly what they're talking about. The epitome of health. I'm I'm not young anymore, but I'm healthy. I exercise. I'm fit. I am highly productive. I all the things. I had a brain tumor that would have killed me when I was 7. And if not for having advancements in science and medicine, I would have been dead. Was I not like good enough? Did I not like did I eat too many donuts when I was, between ages 0 to 7? Like what at what point is that okay that I must have done this to myself or whatever language they're trying to use, but they are perpetuating stigma against the idea that people get
We get
some
sick.
conditions or diseases
Yeah.
that it's just not true, right? And it's unfair to shame people in that way. And so it's the language that they're using and perpetuating a culture that is directly causing harm because you are saying, well, you don't need access to healthcare. I mean, they're literally talking about their pandemic preparedness plan is to be healthy. And it's like, that is
We'll get
wild
on
to
that.
me.
Yeah.
It's just, yeah, it's
Yeah.
just nonsense. It's just erasing the idea that people can get sick and die. And like,
Yeah.
we see it happen.
Yeah,
We've seen it
and
happen.
I think about, people will say, "Well, or I even tell I taught a class recently where I was like, I'm so grateful that here's the MRI or like the device today, what this technology looks like today. And FDA started regulating this device in 1976. And I'll show them what the device looked like in 1976. And I'm like, I'm very grateful to have gotten my MRI in this machine as opposed to that one. But that's what they had at the time, right? Like, however, I think the diagnoses, the technology advances, and so do we, right? Like, why should we go back in time to then have better care? Or it's not better care, right? I understand the language of like wanting to be healthy. Like, what does even that word mean, right? And I think we all, as you said earlier, like no one wants to have disease. And on the flip side of that, everyone wants to be healthy, whatever that looks like. And I think maybe there's differences in opinion of like how we get there. I'm with you though. I have concern of, people not using critical thinking to understand what is actually true. And instead they focus on trust or their gut instinct. And we've had previous speakers on this podcast that really focus on like, how do we actually find what's true and also get the stories that help us identify that truth. Anyway, yeah, it's such an interesting topic.
Well, and that is a critical piece of what we have seen happen is that This is like the fracturing of our shared reality. And if we don't have shared facts, if we don't have a shared reality, how are we going to get to that truth? And if two different realities exist, then what is true? And so right, and so you face this real sort of ethical dilemma of like, how do you approach that? How do you get to that? And because there a set of facts does exist, and the best approximation of those facts is through the scientific method, right? To analyze what is true and is not true to the best of our ability by hypothesis testing. And yet, we have seen the death of expertise, and we have seen science be attacked, and we have seen healthcare and medicine be attacked, in part based on trust, in part based on the leadership, in part, based on this idea of trust, or like you said, trust versus distrust in institutions. And so then you get these sort of niche realities, and that becomes a huge problem. And so how do you assess for what facts are? And so I think getting to that point is actually sort of fundamental to all the rest of it, right? Because if you don't have the shared facts, then how are you going to assess the reality of the situations you're talking about? How are you going to assess how your language is causing harm, or what the morally neutral position is if you don't know what reality is? So I think that's a critically important piece.
Yeah.
We see that we actually see that in the discussions of um, harm reduction and drug use, and the way people frame public drug use, especially. So we're seeing this in San Francisco right now, right? We're seeing this sort of backlash towards harm reduction, and the new mayoral administration, and you have someone on the board of supervisors, Matt Dorsey, who has lived experience, with having a substance use disorder, trying to roll that back, and there's this sort of whiplash effect, and a lot of that is based on misinformation, right? This idea that like tough love is the only answer, which, like, I always argue the expression tough love is inherently idiotic, because love should never be tough. It can be fair, but it shouldn't be tough, right? It's otherwise just a reframing of abuse and causing harm, right? You're just trying to wrap that with a different language to make it sound better.
Euphemism, yeah,
But
in its finest form. Yeah.
right, but forcing people to either choose between jail or forced treatment that they may or may not want, because they are unhoused and using drugs. So therefore, by definition, if they use where they live, they are using in public. That is a form of abuse, versus people who are housed and are using at home are not using in public. Well, we don't see San Francisco police going in and kicking in doors of anybody they suspect using drugs, but we do see them doing that to people in their homes, which happen to be in public, right? And so
It's
we see
fascinating,
this
yeah.
backlash baked on this idea that is not based on facts. And so it's the same idea of like understanding a shared reality and understanding facts and being able to convey evidence on like science-based, communications, right? And so being able to convey the evidence that like actually forced treatment has a much lower efficacy rate than voluntary treatment, and making things accessible, and these other like harm reduction with proven methods, that overdose prevention sites decrease drug use, public drug use, decrease the number of overdose deaths if you're actually trying to do that, right? If your goal is to decrease the number of people who use drugs that are dying, and they show improvements in the surrounding area in terms of safety,
Mm.
people who are using drugs, people who are accessing resources. Like, we have evidence about these things. Those are facts that can be shared, but we don't exist in a shared reality. We exist in a moralizing reality where people decide that people who are using drugs in public are immoral and wrong, and therefore deserve to be punished and abused, versus, well, people who are housed and using drugs they're not they're not they'll say like, oh, they're not causing the same harm to society. How do you know that? What harm did society, like that person who's unhoused, they may be just be using like as a survival mechanism, and they may not be causing any harm. You don't know that. You're only saying that because you see them doing it in public because that's where they live.
Right.
But like that person who's housed, like, I don't know, they might be like beating their partner. They might be causing more net social harm. So you can't actually make those statements. That is not based on reality. That is based on a moral, like a false moral equivalence.
Yeah.
And so the shared reality is an important part of getting to the language and the culture so that you can actually understand that shared set of facts and understand where the language is causing harm. Right.
Yeah.
And so I think sorry, that's an aside, but like, I think
No,
that's
that's
an incredibly
super
important
important.
point
Yeah.
to get to the part of like, how do you create culture change, right?
Yes.
How do you create a change in language can create culture change? And what we're talking about at large here in the context of both, drug use and and regulation, it's like you are talking about culture change. And so how do you get to that? And that culture change really requires a shared reality and a shared set of facts.
Yes.
And then you can make progress. Then you can make progress on language. You can make progress on discussions about technology and medications. And like you said, like MRI machines, I mean, that is also like a mind-blowing one to
Yeah.
me, having done like fMRI research. um Seeing the advancements, I mean, it truly like blows my mind. And the people who understand the like computational side of like the fMRI function, I I took a class in it. I'm just not that
I know.
smart. I don't.
My eyes
I'm
glaze over. I'm like, I'm so glad it exists. Don't,
I'm really glad that there are people who are that
yeah,
smart in
same.
the world who can make those changes and create that innovation. Yeah, I mean, truly.
Yeah. Back to one of the pieces of the link. I'm curious as to your opinion on when people say like a war on drugs, or like as you were saying, like somebody who's using in behind their closed doors in their home. Like, there's also they're creating part of the demand, right? So there's maybe other harm that's happening that, and we keep hearing these like this war on drugs, and we have to go to the source. And I like your thinking of it's a systemic issue, right? There's so many factors. It's multifactorial issue, and just trying to cut off one head of the hydra is not going to lead to any like significant change. What do you think are some of the most important pieces and I don't necessarily like the term war on drugs, but what do you
Yeah.
what do you see as like some of the
Well, no, but
actionable
that's
items that we can do?
a reality, right? The
Yeah.
war on drugs is real. I mean, that was declared. It was declared war on
Yeah.
drugs. What was it, 1971 by Richard
Yeah.
Nixon, right?
Yeah.
Or maybe it was 73. The DEA was 71. I can't remember offhand. Like that is a real thing, and the idea of the war on drugs is what allows us the stigma against. Again, I'm a broken record. I say this all the time. Like the stigma against drugs and the people who use
Yeah.
them is the thing that allows us to cause harm in the world. Right? We're seeing it with people like we're blowing up boats that we suspect of trafficking drugs. We no proof of that, but we just suspect it. And I mean, for a number of reasons, though, the narrative is completely insane. Like, but again, we're not talking about people who are thinking on a system level. And what it requires is systems level change. And we need people who are systems level thinkers to actually be in charge in thinking about how we can redesign all of this.
Yeah.
But what we're doing is we're not thinking about the actual context of like drug passageways and where, like, if we're talking about fentanyl's getting added in Mexico, for example. The parts, a lot of those are being either put together in a lab to create fentanyl is a high potency synthetic opioid. You can create it in a lab, and that is happening, and it's being brought into the drug supply in Mexico, right? But like what we're talking about, if we're talking about drug use, that are drugs that are, being consumed in the United States that are coming from, say, Colombia or Venezuela, like we're talking about cocaine, and that is not fentanyl. And so they're just like creating this narrative like, oh, we're trying to stop the fentanyl epidemic, which one, like, you don't have an epidemic of an inert substance that, like, viruses can cause epidemics, but like humans are putting fentanyl in the drug supply and people are using it and they like using high potency opioids. And so we have people using fentanyl. We also have fentanyl in supply that people don't know that it's fentanyl. They're like pressed benzos that are actually fentanyl. And that's how people are overdosing and dying on things that they don't actually know are that particular drug or that potency. And so it's a misunderstanding of what that reality is. And again, shared reality. And so the narrative around blowing up boats that in this case might be trafficking cocaine, that's not addressing fentanyl, even though that's what they say that they're doing. We have to rethink the entire system. And really, if you really want to get to the root of it, you have to look at prohibition and drug laws. And you go all the way back and you go back into, like, I mean, a lot of it is rooted in racism and xenophobia. And it's the, like, goes back to initially Chinese immigrants and opioids. And then you have the Harrison Narcotics Tax Act in 1914, and then a Supreme Court decision, Wood versus United States in 1919, decided that, so he was a physician, he was giving people who were addicted to, then the available opioid was morphine. He was giving morphine or prescribing morphine to people who were addicted to morphine. And that was decided that it wasn't a legitimate medical purpose, that really he was just trafficking drugs. Now that, again, like racism, xenophobia, then capitalism, it was a tax act. It was not a like drugs are illegal. It was that if you were trafficking drugs, which were legal at that time, you had to pay taxes. So it was a tax evasion, essentially, right? So what they got Al Capone for.
Yeah.
It comes down to capitalism is fighting the war on drugs for us. But if you changed it and you went back to a legal, safe, regulated drug supply, which we did have at a point, the drugs were not illegal in 1914, even when the Harrison Narcotics Tax Act was passed. But it was still rooted in racism and xenophobia that we didn't want those people here to be bringing in their culture and their drugs, frankly. But like ours were okay.
Yeah.
And so if then prohibition happened, and that was all sort of designed here in the United States and was, perpetuated throughout the world, and cartels would not exist if not for the drug illegal for prohibition and the illegal drug trade. Right? And so if we really wanted to think structurally about how we improve the world, how we improve society, how we keep people safe, we have to have a very serious conversation about structural change around drug policy. And that structural change around drug policy has to be around legalization and regulation of the drug supply, which we do a very good job of. Like literally what we're talking about, like FDA regulating drugs, that is a safe drug supply. Like, so we do this already, and we have the systems in place to have safe, regulated drugs. We just call them pharmaceuticals, and then the other ones that people like are drugs.
Yeah.
And so that is, again, we're moralizing about something that carries no moral value.
Yeah. Which come full circle is like, it's just the language that we're using, right?
Yeah.
It's like, it's almost teaching folks a new language, or not necessarily even a new language, just using the correct or the less morally bound terms, right, for these things.
Yeah.
So.
Yeah. Right. And that applies broadly. Again, we're talking about culture change, and culture change is something that applies everywhere in every context, and it applies, to regulatory sector, for
Absolutely.
example.
Yeah. Yeah, and I think of it, let's go back to med tech for a second with and just thinking about I'm clearly very staunchly in the med device world, even though I know a lot about, pharmaceutical medication, biologics, there's a center for
Yeah,
tobacco, there's a
yeah,
center for food.
yeah,
So FDA does regulate all these various things. Um, I find that as soon as you make something hard to get your hands on, either like a class 3 medical device, or even something that's banned or something that they reclassify, uh, it sometimes just drives, bad players deeper underground. And as you said, it creates this new vacuum for cartels or for bad players in that space. It's like we um, create our own destiny in that sense.
yeah,
Yeah.
yeah. It's like we've tried this
Yeah.
experiment before
It's so
and it's
weird. It's
failed,
like,
and yet we keep doing
yeah,
it 50 some odd years later, and we are still doing that,
like a Black
right?
Mirror. What is it?
And
Yeah.
really, I mean, if we want to go all the way back to the Harrison Narcotics Tax Act,
Yeah.
we're 111 years
Yeah.
later, 12 now.
Yeah. Oh, it's so true. Let's go. You've called yourself a cynical optimist. So, what are some of the things that you are optimistic about? Like things that you see either in your practice or in current policies that you think are actually working?
I I call myself a cynical optimist because I've seen the realities of the system that we exist in, but I couldn't do the work that I do if I wasn't optimistic, if I wasn't a believer that there is a better world as possible and that we can create it, and it's up to us to create it. And I want to be a player in trying to make that system better. And so I do like to work in innovation, and I like to work in policy, and I like to build systems because I think that's how we make a better world. But I also understand the realities of the confines of those systems, and it makes me very cynical. And so um, that's where that stems from. And I've worked in the policy space doing advocacy work enough too to see the marginal change that we can make in a policy level, um, but also been really hopeful by seeing some of the changes that we do make. And so getting to do that work makes me optimistic. And yet I'm cynical about what we can get done, um, because I've seen great ideas fail,
Yes.
and I've seen great ideas succeed and make changes, and I've seen great ideas be watered down to be marginally positive, but hey, that's like still positive, right? As long as we're moving the needle in the right direction. So, but you can only keep doing that if you are like almost blindly optimistic about what is possible. And I, I don't want to go into it blind, and I think I have enough experience to not be, but I also am not giving up hope that we can always do better. And so, that's where my work in trying to build a better clinic and trying to build a better system for addiction treatment and trying to advocate for culture change and trying to advocate for policy change. Um, that's where that stems from. And I'm in Sacramento. I am not far from the Capitol. I do a lot of advocacy work. I go to legislators' offices and advocate for policies. I've been involved in, organized medicine, and testified on behalf of bills, or we'll go down and speak to legislators or go listen in on bill proposals, when they're being discussed in committee, because I think those things are really important and impact state level policy, which, directly impacts me. And I think the more people understand the way right, regulation is derived from policy, all of these things,
Yeah.
the policy has such a significant impact. And yet it is just decided by people like you and me who happen to be crazy enough and optimistic enough to also believe that they can help make the world a better place.
Yeah.
And, like a perfect example, one of my neighbors down the street here is one of our state assembly members. she was just my neighbor until she ran for office. And she was always just like a normal, wonderful person who like had kids and would play basketball on the street with them. And yet then she was crazy enough to decide that like she wanted to advocate on behalf of the things she believed in. And now I get to meet her in her office and see people like her who are doing this work and are crazy enough to believe that all together with the right people bringing the right information that we can make the world a better place. And so if we didn't, even people that I disagree with on policy, like politically in general, I have had some of my best conversations with our Republican, congressional representatives, and I am like very much left leaning, and yet they fundamentally believe, like I can think of one in particular where he believes in access to healthcare as a very important thing. And so I've met with him a few times on different bills and talked about that and had the opportunity to have real discussions with him about like, how does this net impact healthcare access, and not discussing the nitty gritty where he was like, oh, well, tax policy, and this is what I believe. Like, no, he just wanted to get into the details of like, how does this actually impact your job in the emergency department or your job in the outpatient clinic, like asking me those questions. And so he's also crazy enough to believe that he can help make the world a better place. And I can have those conversations with him. And so that is where this like insane, cynical optimism comes from, is because I'm there, seeing these patients and seeing the things that we can do to make people better. I mean, getting to work in the emergency department and save lives and see the things that medicine can do is just incredible. And it has to make you hopeful.
Yeah.
Right. You see some of the worst in the emergency department and you see some of the saddest moments, and you have to not let that break you, and take the good from the rest that you do and know that you are contributing to making the world a net better place. And it's hard to balance those things, first of all, but second of all, like, at the end of the day, when you think about it, you're like, God, we are advancing so much and we can do such incredible things. We can literally like get to be in a job where I literally save people's lives. Like, that's wild.
Yeah.
So you can't help but be optimistic about the things that you can do and what humans are capable of, and the fact that we have people who want to make better policy and build better systems. So you have to be optimistic.
Yeah.
But it's fair to acknowledge reality and be cynical about the way that the world unfolds.
Yeah.
And that's okay.
Those
I
two
think
things can
that's
exist in
fine.
the same space, right? I always think of like they don't have to be mutually exclusive, and I always remind myself, I'm like, don't just spiral and be stuck in like in something that is really devastating. Like, what are the ways that we can balance those things out?
Right.
I also love the way that you mentioned, speaking to different people and trying to find the common thread that we have, because I think having those conversations, and I think COVID did not help us in interacting with people that don't maybe agree with everything that we hold as true, right? Like, I think it's so valuable to say, okay, we all want to, as we said, we all want to be healthy. None of us want to have disease if we can help it. And how do we spark those conversations so we can, as you said, make the world a better place? Like, that's what we should all want, right?
Yeah, absolutely. From the side of like, okay, so health policy, that's my like big interest in terms of a systems level, right? We can improve access, and we've seen an incredible spark of innovation in improving access to care, particularly as we advance telehealth, for example. And not that there were any silver linings to COVID, but the lifting of restrictions due to the public health emergency declaration allowed for huge advancements in the adoption of telehealth. That was just kind of slow on the uptake, both on, really, frankly, on the side of physicians. and healthcare systems not wanting to adopt this. And also it frankly didn't reimburse all that well. And so people were like, why would I spend all this money and invest in the infrastructure for a thing that's just going to pay me a lot less? And then it was like, oh, we will just pay equally. And it's not going to be hard to adopt infrastructure because here's all these tools that already existed that just, they were like, yeah, you can use them. Great. And so all of this innovation happens super rapidly of like advancing telehealth adoption, expanding access to care. You could do it from more places, all of these things. And it creates it's still, I mean, so the public health emergency is over, but we still have a lot of policies we're still waiting on some final rules. But we still have policies in place that allow for that ongoing. And so that is incredible. And it gives us a huge opportunity to continue to expand access to healthcare, which has been a huge restriction, particularly within the confines of our healthcare system. And so one of the things that I find exciting is being able to utilize that access to people who typically don't have access to care. So another part of my life, one of the roles that I hold, I'm on the I'm the director of strategic development for Sacramento Street Medicine, a nonprofit street medicine organization, and wanting to expand access and improve the care that we can provide to our unhoused population here in Sacramento. Utilizing telehealth is a very unique opportunity to improve the way we can deliver street medicine and allow for access to, potentially a wide array of people who otherwise wouldn't like be out in the street providing street level care
Yeah.
to these patients. So, to bring it sort of back to the like advancement space and regulatory space, like I think we can, and we are seeing that we can do good and make the world better, and we can find ways that we can be innovative, even though there are a lot of hurdles, right? And even though the system isn't, I mean, the healthcare system is fundamentally broken, as everybody who exists in this country knows and understands, to varying degrees, certainly, but like certainly it's broken. Maybe this is a piece to solving for that puzzle. So that, I
Yeah.
mean, that's something that I'm, excited about in terms of bringing it back to where medtech can advance, and make the world a better place and provide some of that, optimism.
Yeah. Yeah. Especially the push in telehealth, I think in medtech and FDA is also understanding of, okay, if we don't want everyone coming into the hospital, either it's so far away or you're sick, we don't want you coming in. And if you have something else going on, can we address that in a telehealth setting? And then FDA's big push with home as a healthcare hub, right? How do we monitor people where they are? If there's what is it called? The white coat symptom or like syndrome of what you go to a hospital.
Syndrome?
Yeah.
Yeah. Yeah.
And how do you make people more comfortable? And maybe that's being at home, but being monitored. So there is such a cool advancement in this space. And I agree. While I don't like to find too many silver linings with COVID, there were some ways that it forced us to change, right? So sometimes that pressure is the thing that kind of says, okay, maybe it is okay for us to shift the benefit risk. And I always ask this one question to every guest, and you might have touched on it already. Is a medtech a device or some sort of technology that directly benefited you, impacted your life, or of a loved one?
I mean, I would say, the advancements in imaging. I mean, a CT scan is a great example. I had what's called a ventriculoperitoneal shunt, like
This was when you were
as a
7,
result of
right?
having a
This
brain tumor
was
when I was
yeah,
7. Yeah, like those are advancements in technology and medical technology that saved my life. So yeah, I mean, and again, this is part of where that like takes root is I have to believe that we can continue doing better. Like, I owe my life to advancements in medicine and technology. And so it would be silly to like think that we had it all figured out in 1993 and we can't get it better. Like, it's gotten continually better, and it continues to blow my mind the things that we are able to do.
Yeah.
Innovation as we continue to like drive this forward. It's astounding, really, when you think about it. At and getting to see it on the ground too is really cool. You know, so devices specifically. I don't know if you watched the Pit at all,
Yes, I love
but
it.
they so okay, so a perfect example of like a device that is really cool, like maybe not always the most practical in the emergency department setting, but like certainly has contributed to saving people's lives. So they use it in um, mass casualty incident in season one. Can't remember exactly which episode it was in, but they uh, put in a Roboa to a woman who has an arterial bleed in a difficult to access area in her, you know, in her groin and her pelvis. They're trying to stop bleeding into her, essentially into her abdomen, and she puts in a Roboa, and it inflates a balloon that blocks the aorta, and so stops the bleeding below that. I mean, that is incredible. Like, it's a life-saving device that didn't exist, like, really when I even started my emergency medicine training.
Yeah.
So, you know, it is wild to see this deployed and continue moving forward, and the number of lives that do get saved as a result of these advancements is astounding, really.
Right.
So you can't be anything but hopeful.
Yeah. And it's hard to sometimes remind ourselves that of all the good that happens, right? Like, you could look at vaccines, you could look at, regulations around meat processing, right? Like the whole Upton Sinclair's The Jungle. Like, there's so much that based on regulations that were put in place or the science surrounding some of these technologies that's the way that we've moved forward and actually gotten people to live longer and hopefully live a better quality of life, right? So,
Absolutely.
yeah. Last question is, where do people find you? I feel like there's so many cool things that you're working on. I know we didn't have time to talk about is it Vocal MD and like the work you're doing there. But if people want to read more about what you're accomplishing, where do they go? Where can they find you?
I am reasonably active on LinkedIn, which is where we connected in the first place. I have a podcast that I co-host with my colleague Macaulay Sexton, who is a person with lived experience and a recovery coach, where we talk about all things drug policy and harm reduction and recovery related, and really talk more than that, talk about culture change and how do we change the language around drugs and the people who use them, and around recovery and what that means and what that can look like to people in a non-stigmatizing and non-judgmental way. um, those are probably the best places to look me up. I'm also on Blue Sky at tnicholsmd.com, and yeah.
Awesome. Well, thank you so much for your time today. I have loved this conversation and keep doing what you're doing. I think you and I are
Yeah,
both on the
thank
same
you.
page of trying to make the world a better place. And I think we're on the way to doing that. So
You bet.
awesome.
I very much appreciate it, Allison. It was a wonderful conversation. Thanks so much for having
Thank
me.
you.